Today we will discuss an important topic to usability and human factors. Decision Support Systems, DSS, a human factors approach. Decision support systems have been used in a variety of industries, including finance, transportation, and public works, since the 1970s. It had its beginnings in health since the late 1950s, but became a more active area of research and development in the mid-70s. With the growing penetration of clinical information systems, DSS is an effective vehicle for providing real-time guidance to clinicians. DSS includes lower technology solutions, such as paper-based guidelines. However, we will focus on computer-based clinical decision support systems, CDSS, and computer provider order entry systems. The first part of the lecture will focus on the basics of human decision-making. Then we will explore CDSS and consider its potential and pitfalls. We will explore some of the barriers to productive use and consider some options for improving design. By the end of this unit, learners will be able to 1. Discuss factors in understanding human decision-making. 2. Discuss clinical decision support systems, CDSS. 3. Discuss computer provider order entry systems, CPOEs, and clinical decision support systems, CDSS. 4. Discuss barriers. 5. Lastly, how to improve designs. Patient safety has increasingly become a focal concern of all stakeholders in the healthcare enterprise. You have been introduced to the landmark Institute of Medicine report, which detailed the extraordinary number of preventable deaths that are attributable to human error. There are significant complexities in medication management which pose substantial risk for hospitalized patients and a non-negligible risk for ambulatory care patients. We can characterize several phases of the medication delivery process: prescribing, dispensing, administration, and monitoring. Each of these phases provides opportunities for confusion, miscommunication, and error. You may have been introduced to the concept of human factors in several lectures. The focus is on human beings and their interactions with products and equipment, tasks, and environments. The broad goal is to design systems and system components to match the capabilities and limitations of humans who use them. The process we are focally concerned with is decision-making. Making decisions is something that every human being routinely does. Some decisions have greater importance than others. The study of decision-making has been a focal concern of cognitive psychology research for more than 60 years. We can characterize three components of a decision process: choice options and courses of actions, beliefs about objective states, processes, and events in the world, including outcome states and means to achieve them. This reflects our understanding of the state of affairs and the means to change them. Desires, values, or utilities that describe the consequences associated with the outcomes of each action-event combination. Some outcomes are more satisfactory than others, and some risks are more consequential than others. In simple terms, good decisions are those that effectively choose means that are available in a given situation to achieve the individual's goals. As we will discuss, CDSS can transform the means to shape decisions in achieving an individual's goals. There are two focal areas of work in medical decision-making research. The first involves an understanding of how decisions are made. The second involves the means to facilitate and improve the decision-making process in order to improve patient outcomes. In the next few slides, we will focus on Objective 1, understanding how decisions are made. Following that, we will concentrate largely on issues related to the second objective, namely how to facilitate and improve the decision-making process. It is not surprising that humans are fallible reasoners and flawed decision-makers. We routinely witness how society's professional decision-makers like judges, politicians, and coaches make poor decisions. The Heuristics and Biases approaches were pioneered by Tversky and Kahneman, who for many years endeavored to understand the nature of human decision-making. Heuristics are rules of thumb that we routinely use for making decisions. They can be adaptive or maladaptive. Biases are systematic deviations from normative standards. They can significantly impact the process of decision-making and have been well documented in the context of health-related decisions by clinicians as well as patients. Hindsight and confirmation are two of the well-documented biases. Decisions, especially those that were mistakes, seem very transparent after the fact. When one reviews the errors of a family member, friend, or colleague, the situation seems so obvious. In fact, when errors are analyzed after the fact, blaming a culprit seems to be the clear thing to do. This kind of thinking is a product of hindsight bias. This occurs when decision-makers inflate the probability of a prior judgment. For example, diagnose a patient on the basis of subsequent available information. There have been numerous studies documenting hindsight bias. One such study provided clinicians with a set of cases on paper and asked them to rate the probability of a given diagnosis. When they were told the actual diagnosis in advance of the case, their probability judgments were significantly higher. The important point is that the probability should always be the same given a set of facts, such as patient's symptoms and laboratory findings. The inflated probabilities are a product of hindsight bias. So, what does all this mean? Well, biases have consequences for present and future decision-making. If physicians assume they would have predicted a clinical outcome, they may fail to learn from a case. Unusual or noteworthy cases may seem more mundane because they can appear less unusual after the facts are known. We also talked about error attribution. If the answer seems obvious, then it may be easy to overlook a host of mitigating factors that may resurface and lead to more serious errors. Confirmation bias is something that we are all guilty of from time to time. If we have already made up our minds, we are less receptive to the possibility that our decision choice is wrong. We may fail to attend to the evidence. Overconfidence in one's judgment causes a decision-maker to favor one hypothesis over another. We may selectively attend to data and not give adequate weight to alternative possibilities. One finding in medical decision-making is that clinicians are prone to order laboratory tests that may yield no new information about the patient's state. They may merely serve to confirm one's prior hypothesis. There is ample evidence to suggest that clinicians experience difficulty engaging in probabilistic reasoning. In particular, the application of Bayes' theorem has been problematic. Eddy's classic study is an interesting case in point. He presented clinicians with the following problem. Estimate the probability that a woman has breast cancer given that she has a positive mammogram on the basis of the following information. The probability that a patient has breast cancer is 1%. This provides the prior probability. If the patient has breast cancer, the probability that the radiologist will correctly diagnose it is 80%. This provides the sensitivity or hit rate. If the patient has a benign lesion, no breast cancer, the probability that the radiologist will misdiagnose it is 9.6%. This provides the false positive rate. According to Bayes' rule, the probability that this patient has breast cancer is about 8%. Eddy found that 95 out of 100 physicians estimated that the probability of breast cancer after a positive mammogram to be around 75%, a highly inflated value. The test result and its sensitivity seem to be the most salient feature, and the base rate is largely ignored. The deviation between individuals' responses and the normative response as indicated by Bayes' theorem are explained by a bias in which the clinician selectively attends to certain variables that are salient and ignores others such as base rates. Biases are, more generally, predispositions to reason in ways that are not consistent with probability theory. The framing effect refers to the fact that alternative representations of a problem can give rise to different judgments and preferences. Preference for a particular course of action is different when a problem is posed in terms of potential gain rather than potential loss, even though the underlying situation is identical. On the next slide, we will provide an example. For example, When a cancer patient is given a prognosis in terms of survival years, the perception is different from probability of mortality. The difference is just in the presentation, not in the substance. McNeil and others, 1986, presented a hypothetical lung cancer decision scenario to physicians and patients. One treatment option was radiation therapy, which had an immediate higher survival, lower mortality rate, but a lower 5-year survival rate. There were 2 frames for explaining the problem. Frame 1, treatments were described in terms of survival rates. Frame 2, treatments were described in terms of mortality rates. McNeil found that subjects in the survival frame expressed a clear preference for surgery. In the mortality frame, the 2 choices were preferred almost equally. One possible explanation is that the positive framing leads to more risk-averse choices, while the negative framing increases risk-seeking decision-making. The previously described research on decision-making has largely been done in laboratory contexts and not in real-world settings. It is important to keep in mind that decision-making in naturalistic settings can take on a certain character. They are embedded in a broader social context and involve multiple players. Decisions are best thought of as decision-action cycles rather than discrete decisions. In a given setting, there may be substantial stress and time pressure. Increasingly, humans have access to a wide range of tools that assist us in making a range of decisions, from buying a car to maintaining our diet. Decision support systems are interactive, computer-based systems that help individuals use communications, data, and knowledge to solve problems and make decisions. DSS may also include paper-based guidelines and decision charts. But for the present purposes, we will restrict ourselves to computer-based DSS. It is important to note that DSS are intended to assist and guide human decisions, not render decisions in an automated fashion. Decision support systems have been used in a wide range of settings and fields of work, including banks, insurance companies, and hospitals. Clinical Decision Support Systems, CDSS, are tools that provide clinicians, staff, and patients with knowledge and person-specific information, presented at appropriate times to enhance health and health care. They do not provide generic medical advice, but consider patient-specific data to assist clinicians at the point of care. They have been designed to be used for a wide range of medical decisions, including decisions for prevention, screening, diagnosis, treatment, drug dosing, test ordering, and/or chronic disease management. A tricorder is a multifunctional handheld device used for sensor scanning, data analysis, and recording data. In a medical context, it is used by doctors to help diagnose diseases and collect bodily information about a patient. It is the ultimate decision support tool. Moreover, it is safe to say that few contemporary CDSS tools can measure up to the tricorder. Of course, the tricorder is the stuff of science fiction, and it's not likely that we will have such devices anytime soon. CDSS advice comes in several different forms. Alerts and reminders are the most common ones used in the context of clinical information systems. Alerts inform clinicians of potentially negative consequences from following a particular course of action. For example, a system may prompt a clinician that a patient has a particular allergy and that prescribing a particular drug of choice may have adverse effects. A reminder would be used to let a clinician know that it may be time for a patient with diabetes to have examinations of their feet and eyes, given that a certain period of time has elapsed since their last examination. Although clinical decision support systems have been the subject of considerable controversy in medicine, there is much to recommend them for. One of the central premises in the use of CDS systems is to make better use of the ever-increasing available body of medical knowledge. There has been prodigious growth in our understanding of health and disease in recent years, yet this knowledge is slow to penetrate clinical practice. CDS tools offer great possibilities for making knowledge available to the practicing clinician at the point of care. The following list includes some of the possible uses for CDS. Reduced medication errors that cause adverse medical events. I think this speaks for itself. improved management of specific acute and chronic conditions, improved personalization of care for patients. The idea is that CDS tools can offer considerable precision in tailoring therapeutic choices to patients. Best clinical practices consistent with medical evidence. This is a primary goal of CDSS in general. Cost-effective and appropriate prescription medication use. Cost-effectiveness of CDSS has been somewhat difficult to demonstrate. However, there is no question that better treatment, fewer medical errors, and better patient monitoring and management could reduce costs over time. How much guidance should a clinical decision support system offer? This has been a much debated issue for several decades. Early expert systems, although they were rarely used in clinical practice, were oriented to providing answers rather than assists to clinicians. At the other end of the continuum are systems that offer no guidance whatsoever. In fact, some folks argue that any such guidance removes precious autonomy from clinicians. In between, there are a wide range of options. For example, the system may offer a complete set of alternatives for a therapeutic regimen, where it may narrow it down to 2 or 3 alternatives. It may go ahead and automatically execute the action, for example, order investigative tests. It may allow a human to veto the suggested course of action. Most of these choices are hypothetical. Some advocate choice 5 on the previous slide, which would allow the clinician to approve a suggested course of action. Most of the choices from 6 to 10 are hypothetical and would not be allowed in practice. However, it provides one with a sense of the continuum and its effect on clinicians' decision-making. As you know by now, computerized provider order entry, or CPOE systems, support electronic entry of clinical orders for the treatment of patients. They are unarguably one of the flagship applications of clinical informatics. They have increasingly become essential instruments of patient care. These systems enable the partial automation of the medication ordering process. Decision support tools are now an integral part of a CPOE system. In fact, much of decision support research has been conducted in the context of CPOE systems. E-prescribing systems are outpatient systems that support a subset of the functions of CPOE systems. Although CPOE systems remain a controversial technology for reasons that will be discussed later, it offers significant promise. It has the potential for significantly reducing medication errors. Most adverse events in patients occur at the stage of drug ordering. CPOE can result in improvements in response time, efficiency of dispensing, and delivery of medication. The following list enumerates some of the advantages of CPOE systems. Orders can arrive to the pharmacy in less time than they would otherwise. They can be easily integrated into medical records and decision support systems. They can also be easily linked to drug-drug interaction warnings, a very important feature for reducing the possibilities of medical error and so on. On a related note, they can be linked to adverse event reporting systems. In addition, there are claims that suggest that CPOE systems can generate significant financial savings, although the truth of the matter is that the promise of cost savings has not yet come to fruition. They do have the potential to reduce underprescribing, overprescribing, and minimize incorrect medication choices. This scenario was developed by Gil Kupperman and colleagues. It was published as an online data supplement in the Journal of the American Medical Informatics Association. It illustrates how a drug-drug interaction decision support scenario may work in the context of a CPOE system. I will read the scenario out loud. When ordering a new medication, a prescriber may not be aware that 2 drugs interact, or may not be keeping in mind the other medications that the patient is taking. As an example, consider the case of a hospitalized patient who is being treated with venlafaxine, Effexor, for chronic depression, and develops an infection with a drug-resistant bacterium requiring treatment with linezolid, a new antimicrobial agent. The interaction between linezolid and venlafaxine, serotonin syndrome, altered mental status, including agitation, confusion, and coma, neuromuscular hyperactivity, and autonomic dysfunction, is very severe but may not be known to the practitioner. While writing the order for linezolid, an alert screen can warn the practitioner that these two drugs should not be used together. The alert screen may offer the prescriber the opportunity to cancel the order, to discontinue the existing medication that interacts with the newly ordered medication, or to order a test that could detect the interaction or monitor therapy. The alert screen may prompt the physician to have a conversation with the patient regarding potential side effects of the medications. Any of these consequences of the decision support software could be beneficial. In this scenario, the CDSS flags a potentially serious problem by alerting the clinician and offering a set of alternative actions, including canceling the order and offering constructive suggestions to raise the awareness of potential side effects with the patient. This example illustrates the nature of an interaction with a system and a positive outcome. As we discuss later, some interactions are less successful. There are well-known challenges associated with the implementation and use of CPOE systems. The systems are not easy to learn. They impose their own workflow on clinical care. This may be disruptive and even interfere with normal channels of communication. For example, a clinician might have previously had a conversation with a pharmacist prior to deciding on a medication regimen for a complicated patient problem. This CPOE system may serve to reduce the likelihood of such a conversation. In fact, pharmacists who may once have had considerable influence on therapeutic decision-making may be reduced to dispensing medication. These systems often take more time than paper ordering, at least until clinicians develop substantial facilities with the new system. The most important potential problem is the possibility of new types of error. This slide recaps the essential dilemma of CPOE systems at this point in time. There is presently a substantial body of literature on CPOE systems and the use of CDS systems. CPOE has been characterized as an important intervention to reduce prescribing errors, and yet the evidence base for their effectiveness is limited thus far. On one hand, some studies have shown electronic prescribing with CPOE significantly increases prescribing quality in hospital inpatients. However, they have also been shown to introduce new types of errors in the decision-making process. We are now going to discuss a couple of studies that document problems associated with the use of CPOE systems and decision support. The first one is by Jan Horsky and colleagues. He studied the interaction with a particular CPOE system in view to characterize the interaction in terms of effectiveness, changes to ordering behavior, opportunities for error attributable to the interaction process. The example described in the publication involves decision support for heparin dosing, a medication that is used to reduce blood clotting, an anticoagulant. The dose is based on a calculation of the patient's weight. Horsky used a set of artificial scenarios designed to elicit decision support responses. The CPOE triggers a decision support alert and calculates the dose automatically. The study employed a cognitive walkthrough analysis conducted by expert analysts. They also conducted a usability testing experiment in which physicians were asked to enter appropriate orders according to a clinical scenario using a CPOE system. The scenario required a drug dose adjustment for an ongoing anticoagulation therapy. Subjects were instructed to verbalize their thoughts or think aloud while completing the task. Their interaction with the system was captured on video. This is the CPOE screen seen by the clinicians. In the scenario, they were in the midst of ordering and an alert screen popped up. Let's take a closer look at the alert screen. Alerts are often constituted by remarkably complex messages. The critical information is that the appropriate dose should be a bolus of 8,000 units, but the key information is embedded in an extended text and not readily visible amidst the busy message. Not surprisingly, the clinicians experienced difficulty drawing the correct inference from the alert. This resulted in considerable confusion and extended periods of time to process the alert. The alert was not coextensive with typical workflow. In one case, a subject performed all the calculations by hand, and 6 others used the values only as a reference. Subjects also experienced some difficulty understanding how the system performed the computation and were skeptical about its veracity. The format of presentation of the alert was clearly suboptimal. In general, the benefits of decision support were not realized. Part of the problem is that the CDSS process was not consistent with typical workflow patterns. The authors suggest that a different representational form would enable a quick perceptual judgment and could reduce the extra cognitive effort. For example, if the alert would include only the calculated dose in the frame with a clear description of how the result was computed. It would also be helpful to differentiate suboptimal configurations on the screen and replace them with displays based on sound usability principles. Admittedly, this is harder than it seems. The study by Heuristics and colleagues identified some problems associated with decision support and CPOE workflow. In 2005, Koppel and colleagues published a very influential study examining the ways in which a CPOE system facilitated medical errors. The study, which was published in JAMA, Journal of the American Medical Association, used a series of methods, including interviews with clinicians, observations, and a survey to document the range of errors. According to the authors, a system facilitated 22 types of medication error, and many of them occurred with some frequency. The errors were classified into two broad categories. 1. Information errors generated by fragmentation of data and failure to integrate the hospital's information systems, and 2. Human-machine interface flaws reflecting machine rules that do not correspond to work organization or usual behaviors. We are going to illustrate the first class of errors with two subcategory examples. It is a well-known phenomenon that users come to rely on technology and often treat it as an authoritative source that can be implicitly trusted. In this case, clinicians relied on CPOE displays to determine the minimum effective dose or a routine dose for a particular kind of patient. However, there was a discrepancy between their expectations and the dose listing. The dosages listed on the display were based on the pharmacy's warehousing and not on clinical guidelines. For example, although normal dosages are 20 or 30 milligrams, the pharmacy might stock only 10 milligram doses, so 10 milligram units are displayed on the CPOE screen. Clinicians mistakenly assumed that this was the minimal dose. Medication discontinuation failures are a commonly documented problem with CPOE systems. The system expects a clinician to 1. Order new medications, and 2. Cancel existing orders that are no longer operative. Frequently, clinicians fail to cancel the existing orders, leading to duplicative medication orders, thereby increasing the possibility of medical errors. Perhaps a reminder that prior orders exist and possibly need to be canceled may serve to mitigate this problem. As is the case with other clinical information systems, CPOE systems suffer from a range of usability problems. The slide describes three kinds of problems. When selecting a patient, it is relatively easy to select the wrong patient because names and drugs are close together. The font is small, and patients' names do not appear on all screens. In a similar note, physicians can order medications at computer terminals not yet logged out by the previous physician. This can result in either unintended patients receiving medication or patients not receiving the intended medication. When patients undergo surgery, the CPOE system cancels their previous medications. Physicians must re-enter CPOE and reactivate each previously ordered medication. Once again, a reminder to do so may serve to reduce the frequency of such mistakes. The Koppel study is well worth reading. It has received considerable acclaim and notoriety. It is worth pointing out that the CPOE system employed in that study used an old-style interface and was not consistent with modern graphical user interfaces. Nevertheless, this system was widely used, and several of the problems noted in this study have also been observed in the use of other systems. Earlier in the lecture, we were introduced to decision biases. Biases reflect systematic deviations from normative standards and lead to skewed or imbalanced decisions. An automation bias is constituted by a predilection to lean on technology, and in this case, follow the directions of a decision support system even if it does not jive with one's intuition or training. This leads to two classes of errors. 1. Errors of omission, as in the case where a clinician is less vigilant in checking drug orders because they assume the computer will have already done the work, and 2. Errors of commission, in which clinicians tactily assume that if they were not warned about a potentially dangerous drug order by the computer, then there is nothing to worry about. The flip side of automation bias is an anti-automation bias characterized by a distrust or disdain for alerts and reminders. This often leads to advice being ignored. Clinicians routinely disable or ignore the alarms or alerts on clinical monitoring devices. Sometimes the reasons are legitimate. For example, some systems exhibit high false alarm rates for their alerts. Other times, clinicians simply do not want to be disrupted by intrusive alerts and readily dismiss them without giving the advice its proper due. Overriding of alerts is a pervasive problem in the use of CPOE systems. Some studies have documented override rates of over 90%, which is extraordinary in my opinion. Medication alerts should not only warn prescribers about potential problems, but also provide enough information so that they can be appropriately resolved. In a recent study, Russ and colleagues, 2009, observed medication prescribing during routine patient care and identified 15 barriers associated with medication alerts. The next two slides describe 11 such barriers. Some of the barriers have to do with interface issues, such as problems associated with the display of the alert. An alert may not provide adequate information as to why it was triggered. Some alerts may not be evidence-based or do not provide a reference to the evidence. Decisions often involve trade-offs, and some alerts fail to specify the relative risk of patient harm. Alerts can be repeated over the course of an interaction, and clinicians invariably become annoyed by such system behavior. If alerts appear too frequently, they can lead to information overload and prescriber desensitization, thereby increasing the potential for missing key alerts. One complaint about alerting systems is the failure to distinguish between serious problems and less harmful ones. For example, the difference between a genuine allergy and drug sensitivity is often clinically important in making medication choices. Allergies can be very serious, whereas sensitivities are not typically serious. Decision support systems may seem non-intuitive and even perplexing to the user. Alerts may sometimes cause the duplication of work that has already been done or will be done as a matter of course. Alert systems may not adequately reveal their capabilities or limitations to the prescriber. Therefore, the full functionality of the alert system becomes ambiguous. This can increase the level of distrust and perhaps lead to anti-automation bias. In the system evaluated by Russ and colleagues, they found that poor screen display was evidenced by badly presented alert text. The haphazard grouping of multiple alerts in a single pop-up window and the need for scrolling to see a series of alerts. Inadequate alert specification occurred when alerts did not show all clinically relevant information needed for decision-making. We already talked about the unclear level of risk for a given alert and whether it overrides other factors that were part of the original decision strategy. For example, should a clinician discontinue an effective medication because the patient shows evidence of a drug sensitivity? That is clearly a difficult decision to make. We will now briefly consider two important constructs used in human factors and decision-making research: situation awareness and mental workload. CDS systems variably support situation awareness and impose varying levels of mental workload. It has been well established in human factors research that situation awareness and high mental workload can impair memory, problem identification, and decision-making. Situation awareness is a construct used in contemporary decision research to characterize an awareness of what is happening around you with an understanding of what that means to you now and in the future. It can be characterized according to three levels: perception of elements in the environment, for example, cues, stimuli from patient, pulse, color, weight change, chart, EHR, nurse. Comprehension of the meaning of those elements by integrating the disparate pieces of information and determining what is salient. Projection of future status so that decisions can be made. Situation awareness is a product of expertise and experience. Poor situation awareness can lead to impaired decision-making. As information management problems increase, MWL increases. Time pressure makes it more important that CDS automation be easy to use and useful. When you are under time pressure, you have less time and patience to navigate through poorly designed technology. Under time pressure, humans can adapt and still perform reasonably well by exerting more mental effort or by concentrating harder. However, under more significant mental workload, individuals can no longer adapt or compensate in order to maintain cognitive performance. Every human has a threshold where decision-making becomes impaired because of impossibly high mental workload conditions. Demands imposed by the system, for example, clinician needing to remember the important facts of the most recent patient visit while starting the next patient's visit, can readily exceed the attentional resources or mental capacity of the person. This condition is ripe for medical error and compromise of patient safety. We know ways to build a better machine and make it usable by clinicians. CPOE and Jaspers offer some design recommendations. Interfaces must explicitly map to workflow patterns of clinicians. CDSS systems must support, rather than impede, clinical workflows through speedy, available, and usable algorithms that provide parsimonious, clear, concise, and actionable warnings and advice. There should be clues or cues in the interface to optimally support users in medication ordering. They recommend that a clinician should not have to negotiate more than 3 screens to respond to an alert. They also characterize the ways in which the display can be better organized and the alert displayed more prominently on the screen. Karsh also proposes a set of general guidelines to improve clinical information systems and the use of CDSS by designing for better workflow. Clinical systems should help clinicians see the right amount of the right type of data wherever and whenever needed. It is often tricky to determine the right amount. If too much information is available on a given screen or display, it leads to clutter and confusion in finding important information. On the other hand, the alternative is to have the user negotiate additional layers of screens to find the information they need. Clinical information should be accessible in the shortest possible amount of time. A common problem is that the information may be spread across several clinical information systems, making it difficult to find the right information. Data from disparate sources should be aggregated for completeness, so that clinicians are not forced to go to multiple different systems to obtain important information. Computer-based decision support systems offer great promise for the reduction of errors in medicine and facilitation of superior patient care. However, at this point in time, results on CDSS efficacy have been equivocal. CDSS can lead to new types of errors, which present something of a daunting but not insurmountable problem. Adherence to usability and human factors principles can lead to superior design and enhanced performance.